Hi guys, so welcome to the ophthalmology series by BiteMed. So this will be a series of 6 sessions. 4 of them will be free and 2 of them will be premium. BiteMed offers an editable textbook question bank of over 1,500 SBAs and also cases. So feel free to join the premium site, the premium site if you wish. So I think there are some issues with the platform. So we will start very briefly. We'll just wait a few moments and see if that's fixed. Okay, I've been told we're resuming at 6:35, so in 1 minute we can carry on. Okay, I think we're good to go. So we'll start off by just having a look at the gross anatomy of the eye. So if you wanted to just think about what the structures that are labeled from 1 to 12 might be, and we can just go through it one by one, just so we get a bit of an idea, okay? So number 1, we have the sclera. Number 2, the iris. 3, cornea. 4, pupil. 5, lens. 6, ciliary body and muscle. 7, the conjunctiva. 8, which is the vitreous body, also contains the vitreous humor. 9 is the retinal blood vessels. 10 is the macula. 11 is the optic nerve, although the macula should ideally be up here, but we can ignore that. And 12 is finally the retina. Now, when I was first learning the kind of ophthalmology, eye anatomy type areas, I found it quite difficult to know where to start when it came to learning the anatomy of the eye. So the thing that I found the easiest is, first of all, splitting it into layers. So you have the outer layer, the middle layer, and the inner layer. And when you go through the structures around it, it just makes a bit more sense. Or you can do it through the segments. So you can have the anterior segment, the anterior segment and the posterior segment, which essentially tells you about the different types of humor. So we have the vitreous humor in the posterior segment and the aqueous humor in the anterior segment, for example. But for the sake of this lecture, we'll just go through the layers. Then we'll cover the blood vessels and the nerves, and we'll look a bit more at the extraocular muscles. Okie dokie. So we'll start off with the outer layer. The outer layer is a very fibrous layer, and it's involved mainly in protecting the eye. And it consists of the cornea and the sclera, and it's connected by the limbus. So this is the cornea, and this is a transparent structure, and the sclera is an opaque structure, and it's very white. And the limbus would be this area here, and it's essentially the junction between the cornea and the sclera. The cornea is made up of 5 layers, and each of them have their own type of clinical significance. So the outermost layer, we're going from out to in, is called the epithelial layer. And the epithelial layer consists of nociceptors, which are essentially pain receptors, and they help detect any sort of trauma or any foreign bodies in the eye, so they're very important. And then we have the Bowman's membrane, the stromal layer, and then the Descemet's membrane and the endothelial layer. The Descemet's membrane and the endothelial layer are very important when it comes to surgeries such as corneal transplants, because those are the areas that are replaced. It's also a lot of the corneal dystrophies that occur often happen in the endothelial layer of the cornea. And because there's such little vascularization of the endothelial layer, it essentially means that when there is transplants of the cornea, there's a less likelihood of rejection because you're not having as big of an inflammatory process. Okay, and the junction, the limbus, is also quite important because, as I mentioned, the epithelial layer of the cornea is very prone to trauma, kind of abrasions and things. So the limbus secretes corneal stem cells, and that helps maintain the epithelial layer when it does get damaged. Now, going back to the sclera, one thing that you may want to think about for your exams is what clinical sign is often seen within the sclera. So I'll give you a bit of a moment to think about it. So the clinical sign that's often seen in the sclera, it happens when there's a buildup of bilirubin, and that causes a clinical sign called jaundice, and that can lead you to other diagnoses, whether it involves the liver or the red blood cells, etc. Okay. Now we go on to the middle layer. The middle layer is called the uvea, and this was always very confusing when I was in uni because I would think of the uvea as a structure, but it's not. It's three different structures altogether, and it just consists of the entire middle layer, essentially. So the uvea consists of the iris. So this would be the iris, and that's what gives us the colors of our eyes. And it also consists of the ciliary body. The ciliary body involves the ciliary muscles, the ciliary processes, and also these ligaments that you see over here, the suspensory ligaments, that are also called zonules. And then you also have the choroid. And the choroid is very important because it contains lots of blood vessels that are responsible for delivering oxygen to the outer part of the retina. So one thing that you may want to think about for the exams is neovascularization of the choroid and how that may result in a medical, well, an eye-related condition. So just take a moment to think about that. So neovascularization just means new blood vessels are forming. And when those new blood vessels form in the choroid, they're not the same as the blood vessels that are already there. They're very kind of leaky. So when they are leaking, they're leaking fluid and they're leaking other substances, and that causes a kind of blistering formation between the retina and the choroid. And that is a common finding that's seen in wet age-related macular degeneration, so wet AMD. So the ciliary body allows a change in the shape of the lens. Like I mentioned, it's attached to the suspensory ligaments, and the tension between the suspensory ligaments that's created from the ciliary body allows the lens to become flatter or fatter depending on how much tension is put. The ciliary processes is also a very important structure because it secretes aqueous humor. So the processes can be found here, and they would secrete the aqueous humor. We'll cover a bit more of this later on down the line. So the muscles of the iris and the ciliary body are quite important. So the iris controls the amount of light which enters the pupil. So the pupil is essentially just a hole in between the iris, and we're looking now at the eye from a coronal section. So previously, we'd been looking at it from a sagittal section. So imagine this is the eye looking forward. We were looking at it like this. So now we're going to look at it like this. And this would be the iris like this, if that makes sense. So it has two types of muscles. There's the circular muscles, which are also known as the sphincter pupillae, and the radial muscles, which are known as the dilator pupillae, which kind of gives away their function. The circular muscles, when they contract, they contract like this, and that causes a reduction in the pupil size. And then the radial muscles, when they contract, it essentially pulls out the pupil and makes it dilate, and that causes dilation of the pupils essentially. So in bright light, you would expect constriction, so you'd expect the circular muscles to take over. And then in dim light, where you want to see more, you want the pupils to dilate, the radial muscles will cause that dilation. Okay, so ciliary muscles have similar type of function, but the way it works is a little bit different. So when the ciliary muscles are relaxed, these zonular fibers, which I mentioned, the suspensory ligaments, so going back this part, so when this muscle relaxes, there is more tension on these zonular fibers. And when there is greater tension, it actually causes their lens to flatten in shape. And that flattening in shape is used for distance vision. So when you want to see something that's further away, you would have the lens flatten more. The opposite occurs for when you want to see things that are closer. So when the ciliary muscles contract, zonular fibers have lower tension force, and the lens becomes shorter and wider, and that is used for closer vision. Okay. Now moving on to the inner layer of the eye. So the inner layer is simply just the retina, but because the retina has so many functions and different elements, it's a bit more complicated than that. So the retina is just the inner layer. It consists of lots of different types of cells, as you can see, which we will cover. But another aspect of the retina is called the fovea. So the fovea is a small depression. It will be kind of around here of the retina, and it is the area with the highest amount of visual acuity and color discrimination. And it contains a large amount of one specific type of photoreceptors. So if I told you that there's two types of photoreceptors, rods and cones. Rods are used for dim light, and it's more a discriminator of light, whereas cones are more for visual acuity and color vision. What would you think, what photoreceptor do you think will be present within the fovea? Just take a moment to think about that. If you thought cones, you would be correct. Okay, so the retina can be divided into two sections. We have the retinal pigment epithelium and the neural layer. So this is the retinal pigment epithelium, and then the neural layer is essentially the rest of it that's involved in kind of detecting light and transmitting that signal. Okay, the retinal pigment epithelium is quite important because it's a very closely packed layer of cells. And if you think about the layer that's on the outside of it, which is the choroid, which contains blood vessels and they're very leaky, that retinal pigment epithelium needs to be packed together close to be able to stop any kind of unwanted material from entering the retina. So they're very closely packed together, and they're very pigmented. And the reason why they're pigmented is to stop the light from scattering. So when light comes in, so say if it's coming in through the eye, and then it's hitting the back of the retina, it's hitting this layer, and then it's being detected by the photoreceptors and kind of coming upwards and then out through the optic nerve. So this layer needs to be very pigmented so that the light isn't scattered everywhere. Okay, so the neural layer consists of photoreceptors, which are the rods and cones that we mentioned, bipolar cells, which are here, and ganglion cells. We also have horizontal and amacrine cells, but we won't cover those in this presentation. One clinically significant question that you might want to think about is separation of the retinal pigment epithelium from the neural layer results in what medical emergency? So if I told you that this entire area is filled with vitreous humor, and then that retinal epithelial layer is being separated from the neural layer, what's going to happen? So that vitreous humor is going to leak in between those layers, and it's going to cause a vision loss. So the condition that it results in is retinal detachment. Okay, so in terms of retinal cell signaling, as we mentioned, there's Yes, retinal detachment. I think someone asked a question. Yes. So one thing that we were speaking about was retinal cell signaling. So essentially the difference between when there is light versus no light. So this isn't dark, this is the absence of light. When there is light, the photoreceptors are hyperpolarized, and this leads to signal transduction, which leads to activation of the optic nerve. But then in the absence of light, the photoreceptors are depolarized, which means no signal transduction, and then no kind of signaling through the optic nerve. So the way this works is once the ganglion cells are activated, they have axons and they project along the optic nerve, and they send this stimuli to the brain via the optic nerve. So if you want to think about which cranial nerve the optic nerve is, and it'll give you a clue as to what you're testing for when you're doing the cranial nerve examination and why the different tests for testing the optic nerve is significant. Okay. So just a recap of what we've covered so far. We have the outermost fibrous layer consisting of the cornea, the sclera, and the limbus. Then we have the middle uveal layer, which consists of the iris, the ciliary body, and the choroid. And then we have the inner retinal layer, which just consists of the retina. Now we'll move on to kind of seeing it a bit more differently. And by this, I mean seeing it from the different segments. So we won't go too much into the posterior segment because that's pretty much just the vitreous humor. We'll talk about the anterior segment. Now, this is a lot of the times confused by the anterior chamber and the posterior chamber, but they're very different. So if we split it like this part is the anterior segment, this part is the posterior segment. This is the anterior chamber in front of the iris, and then behind the iris, we have the posterior chamber. Okay, so the anterior chamber produces, and the anterior segment produces aqueous humor, or consists of aqueous humor even, and the posterior segment consists of the vitreous humor, and that's another way to differentiate it. But the anterior chamber and the anterior chamber and the posterior chamber are two different structures. So this is the posterior chamber, and this is the anterior chamber. So behind the iris, posterior, in front of the iris, anterior. And the reason why this is significant is because, as we mentioned before, the ciliary processes produce aqueous humor. And this aqueous humor first enters the posterior chamber, and then it goes through the pupil, which is just a hole in the iris, through the anterior chamber and the trabecular meshwork, canal of Schlemm, and out through the drainage systems. Now, the clinical significance of this is when this trabecular meshwork element is disrupted, it results in a very common eye emergency. And just take a moment to think about what that might be. Okay, so the emergency that it leads to is glaucoma. So depending on open or closed angle, both involve dysfunction of the trabecular meshwork. They have slightly different pathophysiologies, but dysfunction of this process is what leads to the buildup of the aqueous humor and then to the eventual vision loss. Okay, now we'll move on a bit to talk a bit more about the vasculature of the eye. So the main artery which supplies the eye stems from the internal carotid artery, which gives rise to the ophthalmic artery. And that splits into the central retinal artery and the lacrimal artery. So the central retinal artery supplies the internal retina and the optic nerve fibers. And this is clinically significant because if you think about central retinal artery occlusion, there's specific findings that you'd see on a fundoscopy that would kind of coincide with blockage of this artery. So just think about what you would see on a fundoscopy for a central retinal artery occlusion. Okay, if you said pale retina with a cherry red spot, that would be correct. So the reason why it's a pale retina is just because there's no blood supply to it. The reason why you have the cherry red spot is actually very interesting because essentially that red spot is where the fovea is. And if you remember, the fovea is kind of a dip in the structure of the inner retina. And because of that dip, it means it's closer to the capillaries of the choroid and other vasculature. And that's what gives it that red color. And then we have the ciliary arteries, which supply the structures of the uvea, so the iris, the ciliary body, the choroid, etc. And we have the conjunctival circulation, which is both from the ophthalmic artery and the external parotid. So venous drainage of the eye involves the central retinal and vortex veins, which join to form the superior and inferior ophthalmic veins, and they empty in to the cavernous sinuses, the pterygoid venous plexus, and also the facial vein. I think this part is a lot more visual, so if you can find a way to visualize it within your brain, it will make it a lot more easy to understand. Okay. So now we're going to go to cover a bit of the extraocular muscles of the eye. So we've already spoken about the optic nerve, which involves the actual vision aspect. Now we'll talk about the oculomotor nerve, the trochlear nerve, and the abducens nerve, which are involved in the kind of movement of the eye and the muscles of the eye. So the oculomotor nerve supplies the medial, inferior, and superior rectus, along with the inferior and levator palpebrae, and also the sphincter pupillae. And when you kind of understand the functions of these muscles, it makes sense why dysfunction of the nerves, such as a palsy, would result in the symptoms that they present with. So if all of these muscles didn't work, essentially these would take over. So when the medial rectus, the inferior rectus, the superior rectus, and the inferior oblique do not work, the superior oblique and the lateral rectus take over. And that results in that down and out kind of clinical finding that you see. Because the levator palpebrae is involved in elevating the eyelid, you'll see a ptosis. And then because the parasympathetic nervous system innervates the sphincter pupillae, you'll have mydriasis, which is essentially just dilation of the pupil. The trochlear nerve palsy would result in vertical diplopia because the superior oblique muscle would no longer function. So when you're trying to look down, essentially you'd have this sort of double vision, and it would be on the vertical plane. And then abducens nerve palsy would result in a squint because the lateral rectus, the medial rectus would take over because the lateral rectus wasn't functioning. Okay, so if you have a look at these images and try to guess which of the nerves correlate to these clinical findings. I'll give you a moment. So this is the convergent squint, which is essentially esotropia. The eye just looks inwards. This happens a lot with babies because of various congenital conditions, and that's usually corrected with patches and etc. But it happens in adults when there is a palsy. And then with this one, this would be the oculomotor nerve palsy. As you can see, it's looking down, the eye is looking down and out. There's also dilation of the pupil, and the eyelid is drooping, which is the ptosis. And this is an example of vertical diplopia because it's on the vertical plane. If there was horizontal diplopia, you'd see two things, but it would be on the horizontal plane like this. But because it's on top of the other, it's seen as vertical diplopia. Okay, so that was a very quick kind of talk about the anatomy of the eye. So if you wanted to fill out a feedback form, that would be very appreciated. But everything that we've spoken about today will be provided in a handout. If you add your email within the feedback form, that will all be emailed to you. Okie dokie. Thank you for listening.